Okay. Oh, we've got lots of people joining us. That's great. Thank you for waiting patiently, everyone. You're probably sitting in a waiting room, hanging around for a bit. So for those of you who don't know, I'm Jen, and I am the Marketing and Communications Manager for Arrow, the Bone Marrow Transplant Foundation. And we're bringing you this webinar tonight called Transplant Talk Live. And it's kind of the live version of our monthly newsletter where we get to go into a little bit more detail on some of the topics that we cover there and on our blog. And this series of webinars has been made possible. Sorry, I don't think I highlighted myself, did I? That's probably better. The series of webinars is being made possible by some funding through Tour de Cure, so we're really thankful to them for that. And I'm going to introduce you now quickly to our panelists. You should be able to see them on screen soon. Okay, there we are. So tonight we have Dr. Ashvind Prabahran joining us. We have Alex Rivalland and Yvonne Panek-Hudson. All three of them are joining us from the lands of the Kulin Nation down in Victoria. Are you all in Melbourne, I believe? So that's Naarm in Melbourne. And I'm coming from up on the north side of Sydney on the lands of the Dadamuragal people, way up near Pimble and Turramurra. So a long way away from these guys. Tonight we will be talking about long-term care post bone marrow transplant. If you have questions for our panelists tonight, we would love you to ask them and put them into the Q&A panel. That's what we will be monitoring for questions tonight. And just a note that I know many of you will have really burning questions that are really specific to your particular situation. We can only answer general questions tonight though, so please keep the questions sort of fairly generic and general. If you've got questions that we can't answer tonight, I encourage you to go and talk to your care team, your transplant team. And with that, I am going to hand over to Yvonne to host tonight's conversation. Yvonne, you may recognise her voice when you hear it because she's one of the co-hosts of the Straight and Marrow podcast. Over to you, Yvonne.
Thanks, Jen, and thanks to Arrow and it's such a wonderful event, these webinars. And as you know, this is webinar 3, and the last 2 have been incredibly successful. And interestingly, we've had a lot of feedback, a lot of positive feedback, and a lot of people have been asking us for a webinar on supportive care, self-care, long-term issues, how to get on with things after transplant. And as you know, what you ask for, we deliver. And so we're absolutely delighted to welcome Ash and Alex tonight. You will, for fans of the Straight and Marrow, you will recognise Alex as the co-creator and co-presenter on the Straight and Marrow. And you'll recognise Ashvind as well, because I think, Ash, you've featured 3 times. 3 times on the Straight and Marrow. So he was so popular, the first time we invited him back for another 2 presentations. So look, without further ado, I'd like to introduce both Ash and Alex to you. So Ash is a consultant haematologist and a bone marrow transplant physician, and he works at the Austin in Melbourne and Monash Medical Centre, and previously with us at the Royal Melbourne and the Peter MacCallum Cancer Centre. And yes, Ash, we miss you very much. Ash has a special interest in myeloid disorders, bone marrow failure syndromes, and allogeneic stem cell transplants. After completing clinical and laboratory training in haematology, Ash was awarded the Maddie Rewalt Vision Victorian Cancer Agency Travelling Fellowship. And through this fellowship, he completed a PhD through the Australian Cancer Research Foundation Laboratory at the Royal Melbourne Hospital and the National Heart, Lung and Bone Marrow Institute at the National Institute of Health in the United States. And Alex, I'm going to introduce you as well because you're going to follow Ash. So Alex Rivalland is a clinical nurse consultant, nurse practitioner candidate, soon to be working as an endorsed nurse practitioner, specialising in long-term issues after transplant, so post-transplant care, specifically graft versus host disease. So Alex works at Peter Mac and the Royal Melbourne Hospital as the graft versus host disease nurse consultant. Amongst other postgraduate studies, she's completed her Master's in Advanced Nursing Practice, as I mentioned, and will be working as a nurse practitioner soon. And Alex's particular practice and research interests are in post-transplant care, palliative care, viral infections, and optimising and educating carers, as well as graft versus host disease management. So welcome to you both. Thank you for spending your Tuesday evening with us. And Ash, over to you.
Thanks, Yvonne. Thanks for that introduction. I'll just... is that projecting okay there?
Yep, we've got it. We can just see your notes, though. You'll just need to change your view to...
Okay.
Yeah.
Let me try again. Is that still the same?
Yeah, it is.
Okay.
Maybe jump out and jump back in.
Yeah, I'll do that.
Yeah.
For
those of you of a similar vintage to me, you'll remember overhead transparencies. We never had problems with overhead transparencies.
This is the hardest part about presenting.
I'll try it this way. Is that better?
Yep, that's it. You've got it.
That's it. That's great. Okay.
Thanks, Ash.
Thanks everyone. Sorry about that technical mishatch. Thanks for the opportunity of presenting to everyone today. This is the title of our talk. As Yvonne said, my name's Ashvind Prabahran. I'm a haematologist and BMT physician at Austin and Monash Health, but I primarily practice allogeneic transplant at the Austin. So in this presentation, it is a very kind of doctory focused presentation. I apologise for that. There's probably more relevant information in Alex's talk, but I just thought just to frame Alex's thought, I would go through kind of the nuts and bolts of post-transplant care. And then just briefly at the end, I'll just discuss some of the challenges that I've observed patients face in the post-transplant period and what I've observed to be potentially successful ways of dealing with those challenges. So this graphic just represents the timeline of an allogeneic stem cell transplantation, where at the start of everything, patients are admitted to a haematology ward and given chemotherapy. Stem cells are infused on day 0, and then from this period, from day 0 to 2 to 3 weeks later, it's quite a rocky period in hospital. People are quite unwell, but at the point of recovery, TPN cease, you're off antibiotics, you're on all your tablet medication, and you're looking at leaving hospital. And I guess the big question is what happens next. So even though you've left hospital, there are still a few things that we like to keep a close eye on. So one is how are you progressing with all the numerous amount of medications that you need to take? Are there any potential signs that there may be relapse of the underlying disease that you were transplanted for? Are there any infections, which is a big concern of us for us after a transplant? And are there any signs of graft versus host disease? So let's talk about medications. The first thing I'll do is just I group medications into their overall function. So the first group I'll talk about are those that prevent graft versus host disease. So they include cyclosporin, tacrolimus, mycophenolate, and they come with quite a lot of side effects, and they're often the hardest drug for people to take. So these include nausea, fatigue, high blood pressure, issues with kidney function as well. The next group of drugs are those that prevent against certain types of infections. So these names might be familiar to you. So there may be an azole like posaconazole or voriconazole that prevents against fungal infections, Resprin, which prevents against a specific type of infection called PJP, valacyclovir, which protects against herpes viruses. And some of you may have had access to something called letermovir, which is often used to prevent CMV infection. And these also have side effects such as nausea, abnormalities on your blood tests to do with your liver function or kidney function. It can also be a difficult group of drugs to take for a prolonged period of time. And then the final group of medications that probably are the most important are those which I've grouped in supportive care. So anti-nausea tablets such as ondansetron, metoclopramide or Stemetil, Urso, which is something that we give to protect your liver, which is also quite a difficult drug to take in terms of nausea. And then also electrolytes like magnesium and potassium replacement. So because you're on so many medications and you may be on a lot of medications for a while, part of the reason why we see you so regularly is just to see how you're going with the medications, whether we can manage any of the side effects, whether we can give you a better regimen to try and manage all the side effects potentially, because we need to, it's important to be on them and we need to give you a strategy to manage that. So graft versus host disease is one of the most concerning complications of a transplant. And I've just put this graphic here on the left-hand side just to demonstrate what the mechanism of graft versus host disease is. And it's primarily mediated by a type of immune cell that comes from your donor called a donor T cell. And it starts attacking parts of you, and it's predominantly focused on these three organs here, the skin, the liver, and the gut. It usually occurs from day 30 to 3 months following a transplant. And we most commonly see it when we come to the routine reduction of the preventative medications, such as cyclosporin and tacrolimus, so roughly around kind of day 80 onwards. And as I said before, it commonly affects these three organs, and the manifestation of this occurs in these three organs. So with the skin, it may come up as a rash, and quite a significant rash, encompassing your whole body, abnormalities on blood tests reflecting your liver function, and then the thing that we get most concerned about is when it starts affecting the gastrointestinal tract, so the gut, and this can come about as nausea, significant pain, and diarrhea. There are treatments available, so quite commonly we put you on a dose of steroids, such as prednisolone, because that suppresses the donor T cells. But we may also increase your other medications back up to their prior levels, such as the cyclosporin, tacrolimus. And then a newer agent that's become available that we're using quite frequently is also ruxolitinib. So just to give you an idea of the incidence of graft versus host disease in Australia, I managed to find, it's probably an older copy of the Australian Bone Marrow Transplant Registry data summary from 2019. I don't expect the rates to change that much in more recent data, but this just gives you an idea of how likely a patient is to have graft versus host disease after a transplant. And as you can see here, the rates are, of graft versus host disease, which we grade as grade 2 to grade 4, are roughly almost around 20% after a transplant. So a significant proportion of patients may experience some form of graft versus host disease after transplantation. So infections are a significant problem. So these occur as a result of the conditioning chemotherapy and also the medications used to prevent graft versus host disease. The ones that we actively monitor levels for, and we don't have immediate access to any medications that can prevent them, is CMV and EBV. The idea is that we like to monitor the levels of these viruses before they become a problem and you start manifesting signs of infection. That's usually done through a blood test that's done every week and often twice a week, looking for the levels. And the last thing I'll say overall about infections is at this stage of your transplant, it's very common to come back into hospital. So it doesn't represent a major setback. And the most common reason to come back is with an infection. And usually the manifestation of that is a fever. So you've gotten to this magical milestone that's more or less arbitrarily drawn a line in the sand called day 100. And there's two broad group of patients that I kind of categorize patients as those who should be cautiously optimistic and those that should be cautious. So those who fall within the cautiously optimistic group, and to be honest, I have to say, and I hope this reassures a lot of people, this group of patients actually it's a minority of patients that we transplant in the modern era. So those are the ones who have gone without any graft versus host disease, no difficulties with infection, have more or less complete donor chimerism, which is a measure of how much of your blood is your donor cells, and no signs of relapse. The other group of patients, which we'll talk about later on, are those that should be cautious. So those that have experienced some acute or chronic graft versus host disease, recurrent infections, low to medium donor chimerism, and some potentially early concerning features of relapse. So in terms of the cautiously optimistic group, so what will happen if you're the lucky ones that fall in this, this minority of patients who we talk about being cautiously optimistic, we'll be looking at ongoing monitoring for signs of graft versus host disease, ongoing blood tests or PET scans to look for chimerism and signs of relapse. And then we reach this stage where we look for the late effects of transplantation. So monitoring for any signs of early osteoporosis, so bone health, cardiovascular health, lung health, and then often domains that, I'll be first to acknowledge that hematologists as the doctors as part of your transplant team aren't really good at looking after, but other members of the team are good at looking after and are also very important to your quality of life, mental health, sexual health, and also fatigue. Fatigue is a big issue. So on paper, it may look like you've gotten through the transplant without any issues, but it is very common to just feel fatigue and take a while to get back to your pre-transplant level of functioning. The other thing we look for is it's starting your revaccination process because you're dealing with a new immune system. And then if you're lucky enough to be in this cautiously optimistic group, contemplating return to work or normality around the 6-month mark. So before I launch into the talking about what we watch out for in the cautious group, the group that was coloured yellow on my last slide, I'll talk a little bit about chronic graft versus host disease. It's a little bit different from acute graft versus host disease. First of all, it's mediated by a whole different range of donor immune cells. So we know that T cells are involved and also B cells, which you may have heard of. They're primarily the cells that produce antibodies in our body. And then they're sort of garbage disposal units. That's the best way I can describe this cell type, called monocytes. So they're the ones that are coloured purple here. So they all have a potential causative role in chronic graft versus host disease. It's also classified as chronic if it occurs probably 3 months after the initial transplantation, and slightly different organs can be affected, including the skin, and this includes the genitals as well, mouth, eyes, gut, liver, and lungs. Often we need because it is a chronic condition, both in name and also the duration of illness, we need different team members involved, depending on the organ that's involved. So there may be a respiratory doctor in your care, a dermatologist to look after your skin, an ophthalmologist, and then also a dentist to look after your dental care. And the treatments depend very depending on the organ affected, but often you will be on some sort of total body treatment. So this may be steroids, some of the other drugs that suppress the immune system, including cyclosporin and tacrolimus. Also, we use a drug that depletes B cells called rituximab, and then again, ruxolitinib has been put on the PBS to manage some of the difficult to treat chronic graft versus host disease as well. So this is a drug that's had emerging evidence in this. And there are other modalities, and I was reminded this morning just about ECP as well, but that's only available at certain centres. So, but that's some of the treatments that have shown efficacy in chronic graft versus host disease. So again, just some cumulative incidence curves which measure the kind of proportion of patients who will experience chronic graft versus host disease. And you can see that it's actually a sizable proportion of patients who are undergoing a transplant in Australia, so up to 40% and maybe slightly higher, will experience some grade of chronic graft versus host disease after transplantation. So those who do not are actually probably in the minority of patients. So regarding the specific treatment of the cautious group, so again, there'll be ongoing treatment of chronic graft versus host disease, ongoing monitoring for complications of graft versus host disease treatment, and this is particularly focused around prevention and early treatment of infection. And then there are some late effects of graft versus host disease treatment and the drugs that suppress the immune system. And again, it's looking at bone health, particularly with osteoporosis. We know that having chronic graft versus host disease and being on immunosuppression also accelerates some of the normal aging that happens in your cardiovascular system. So it's important to maintain a reasonably healthy lifestyle and control things like blood pressure and cholesterol, and that will be managed as part of cardiovascular health, making sure your respiratory and lung health is okay. And then again, these three domains which I talked about are even more important in terms of trying to manage and seeking help to manage mental health, fatigue, and sexual health. So just a few comments about relapse. It's a major source of anxiety, I know, for all of you and also for us as looking after you, because this is primarily the reason why you went through a transplant. But we are trying as a specialty, and we're investing a lot of research into trying to predict relapse early and thus treating it early, because we know if we manage relapse at very low levels, the outcomes for patients are a lot better. There are certain tricks up our sleeves, such as donor lymphocyte infusions, where we take an infusion of immune cells from your donor and use that as a potential treatment for relapse. And there are increasingly the availability of medications that may be able to treat low levels of relapse and target specific types of leukemias or lymphomas that are sometimes used to treat relapse. And the evidence base for this is growing as trials increase. And then the other thing to say is the further you get away from the transplant, the risk of relapse reduces over time. So I just thought I'd put, I guess, from my observation, and I always feel like a bit of a schmuck talking about this because even though I'm a haematologist that specialised in BMT in transplantation, you know, I've only experienced it as an observer. I've never gone through the process, so I'll caveat all my information with that statement up front. But from what I've observed, there's three big challenges that patients go through. One is dealing with the signs and symptoms of graft versus host disease, particularly chronic graft versus host disease and all the complications as a result of that. Dealing with relapse, or more I guess the uncertainty around relapse occurring in the future. So the potential for relapse is a big challenge. And then also just looking at your journey as a whole, the long treatment durations with no clear end in sight. So with these challenges in mind, I just thought I'd provide some, I guess, strategies that you can use to potentially cope with them that I've observed patients have said that they've been successful. So first of all, I think trying to stay as active as possible is a useful thing. You get the endorphins from exercise. It also improves your physical robustness, so you can attack any potential challenge. And we're not. I'm not saying try and run a marathon or try and squat, 70 kilos, but trying to do anything you can within the physical restrictions that you have because of your illness, I think is also something that gives you a little bit of routine and may also improve your quality of life. Keeping to a routine, I think that helps as well. The other thing is trying to reduce your horizons, not from year to year, but potentially from day to day to week to week. And it may be easier to measure your gains over those time periods rather than striving for longer durations. It's harder to measure when you're looking out into too far a distance. The other thing I've noticed is, and one thing I want to emphasize, it may be a bit of controversial advice, but reducing your infection risk does not equal social isolation. So I think a lot of us have had practice of this through COVID, but you want to try and make an attempt to maintain those social connections, try and see the people who are important to you, provided they don't have any active signs of a viral illness. Trying to get out to shops or restaurants, not at peak times, but also it gives you a bit of time to go and experience life with a few restrictions. And you can improvise as well. And like I said, our through COVID, we've had a lot of practice of that as well. There is a lot of uncertainty that I think a lot of you will deal with in the future. And to be honest, I find it hard to advise about what the best way to manage that. I've had a patient who's had a good experience with a psychologist, and I think that psychologist gave them some coping strategies to deal with uncertainty. And if you find a psychologist that you gel with, or you have a psychology, if your BMT unit has a psychologist that's associated with it, it might be worthwhile chatting to them and talking to them about coping with uncertainty, because no matter what reassurance we can give you as your treating doctor, that there will be a lot of uncertainty in your future that you may need to manage, and it will be useful to have some psychological tools to cope with that going forward. So just some concluding remarks. Obviously, after leaving your hospital, we'll continue to monitor you through your transplant journey. The main things we'll be looking for are signs of graft versus host disease, relapse, infection, and how you're traveling with your medications. After that totally arbitrary line in the stand, 100 days, we will continue to monitor things, but the frequency and the intensity of monitoring will depend about whether you're in that cautiously optimistic or cautious patient group. And last thing I'll talk about before I hand over to Alex is essentially tough times never last, but tough teams do. And this is a team sport, and we all have different focuses, but our main focus is you and getting you through your transplant journey. So with that, I'll conclude, and I'll hand over to Alex.
Thanks, Ash. That was absolutely brilliant. And, I particularly like your strategies and your final message around a team, because, we sometimes we feel like we say it a lot, but it does take a village in transplantation, the patient, the family, friends, and the healthcare team. So thanks again. Without further ado, I'd like to welcome you, Alex, to share your screen.
Thank you. Well, before I share the screen, can you hear me?
We can.
I wanted to just agree with you on every point, obviously, Ash, but particularly when you say reduce your horizons to day by day, week by week. I often feel like the length of time that transplant takes to recover from makes it really hard for people to sometimes like lose the forest for the trees as such. And I really encourage people, and I mean, this is applicable to anyone, but encourage people to, you know, yes, you're not back to your normal baseline, but like, when was the last time you had a blood transfusion? When was the last time you were admitted with an infection? Like, there are ways to count gains with things like that. So like, and day 100 is entirely a concept that we're working towards, not a date. The concept is, you know, transfusion free, GvHD free, infection free, fabulous. And it will happen. But, you know, we've never done this transplant in that body before. So it might happen at day 80, it might happen at day 100, it might happen at day 180. And the psychology input, I almost wish it was like I highly encourage it for everybody, because it's really hard dealing with the uncertainty and the risk of relapse. And Yvonne, you and I interviewed someone, a beautiful psychologist, and she was talking about various strategies to help deal with uncertainty, and be that relapse, be that graft versus host disease. And she had strategies around like worry time. And I think that that's really beneficial to put into your daily practice. But now I am struggling with my devices, so I will do my very best. But I am on two things. So can you see my screen? Yes. Is it on presenter mode?
We can see your slides to the left of our screen, so we can't see speaker notes. Maybe
Well,
now, yep, you're good, Alex. Well done.
Yeah. So you've already been introduced to me before, and I was thinking of taking this opportunity to talk about graft versus host disease, but I truly welcome any interruptions if there's anything anyone else wants to know more about this in particular. And I think I was tempted to talk about this because I feel like graft versus host disease is the bogeyman of transplant. Like, yes, here's your cure for leukemia, but also there's this undescribed, quite challenging plethora of symptoms that you might experience. And we do, in a way, and I guess this is the way we give information, is that you think of day 100 as over, and then perhaps you can go back to normal, but your recovery isn't over at that time point. And it is actually still really important to pay attention to your body in the days, weeks, or months or years, perhaps, after your bone marrow transplant, to look up for the signs for graft versus host disease, and or perhaps relapse, or whatever it may be. And your team will be there to help you as it's happening. So, you know, if you haven't been diagnosed with graft versus host disease and some of these symptoms ring a bell, reach in with your transplant team. They probably will be able to give you some ideas. So I'm jumping ahead slightly, but you can absorb this slide. I'm like, what is graft versus host disease at its core? So essentially, it's when the cells from the donor, the graft, right, see your body's cells, the host, as different and attack them. And then we can give them medications to help lower you getting a risk of graft versus host disease. But regardless of the various treatments we have in place to prevent GvHD, people still get GvHD. And it can range from mild to severe. And various patients will have graft versus host disease symptoms, even though they might range over time to being significant or not. And it's not always a bad thing, even though it's, one of the scary things of transplant that we talk about. Perhaps if you had a bone marrow transplant for a blood cancer, we might assume that some form of graft versus host disease is a good thing. Not always the case, but we could possibly assume that the cells are working to destroy new cancer cells. And it's important to understand this is a whole immune system process happening. And there are two types of graft versus host disease, which Ashvind has gone over, and so I'll skip. But I thought, okay, all this information. What are we going to do about it? So first of all, what can you as the patient do to actually prevent graft versus host disease? Because there's treatment decisions we'll make, but sun safety is very important. You need to avoid the sun as much as possible. Wear a hat, sunglasses, long sleeve pants. The idea is that if you were to get a sunburn, an inflammatory process, that could trigger graft versus host disease in and of itself. And so we could just bypass that whole problem with a bit of slip, slop, slap. You want to avoid infections as a general rule. And Ashwin's 100% right. You don't become a hermit and live on your own. Absolutely not. But you can just have common sense. Avoid crowds, avoid people who have active infections. You don't want to see your cousin or your auntie who has a runny nose. You can just leave that be. Avoid gardening or digging in dirt, smoking or being around people who are smoking, construction sites if possible, and then in general, being aware of what the signs are so that early intervention is helpful. And I'll talk you through how to do that shortly. And taking your medication. A lot of people will say that the reason I'm sick is because I'm on cyclosporin, and you're right. You know your body and you're 100% right. You are sick taking cyclosporin, but it's the method to the madness, unfortunately. It's part of the plan, and we need to support you as best as possible to take these immunosuppressive medications. So whilst you can do that little bit, what can you do to self-assess? So I've got a couple of pictures here, and it's a bit of a head-to-toe assessment. So, when you look at your skin, you can, if you are experiencing itchiness, dry skin, tightness in your joints, perhaps sores or rashes. Ashvind described the rash before. It's a very fine red rash that will cover most of your body. And if you're anxious about is this or isn't this a graft versus host disease rash, do not feel any pressure to make that decision on your own. Please just call your transplant center, your nurse or your doctor or whoever it may be, and we will be able to help you with that, because rashes are one of the hardest parts to get your head around in this whole process. There's some other little late signs of graft versus host disease around, like the nails. You could get brittle nails or ridging in the nails, and I can talk to you a little bit later about how to fix that. Hair loss, itchy scalps, that's something to consider. Eyes, I've had one patient who described himself as everyone thinks I'm on ice. And I was like, no, he has very red eyes, itchiness, dryness, and sensitivity to light. We can hopefully fix this, but the earlier, as with all of these symptoms, the earlier we get involved, the better. So please don't ever hesitate to escalate. Mouth, you could get ulcers in your mouth, difficulty opening your mouth, sensitivity to spicy food or toothpaste or carbonated drinks. That's something to escalate. Something can happen in the bones of your body. Maybe you could get cramps, or cramping in general is normal, but if you get consistent cramps over time and you can't find a correlation in your general life, that's something to escalate to your transplant team, as is joint stiffness, tightened muscles, any difficulty with range of motion. That's really worth saying. So the gastrointestinal effects from a chronic graft versus host disease perspective can be a little bit more subtle compared to the acute GvHD. So where you might experience an inability to eat, or nausea, or profuse 10 times per day diarrhea, maybe it manifests in this phase as a difficulty swallowing, soreness in the mouth, reflux, an inability to keep your weight on. That's worthy of bringing up. And as Ashvind said, genitals, unfortunately, can be affected. You think you've gone through bone marrow transplant, you've had enough. Your sex life surely shouldn't be affected, but unfortunately, for some people, it can be. And what that would manifest in women might be pain when you have sex, difficulty or painful urination, dryness, burning sensations. For men, it might be difficult to pull back the foreskin. It's just worth knowing that this could happen. So knowing that you can escalate this and we could probably fix it if need be. So treatment for all these different things will, and I'm not going to go into a full, because this isn't a one-on-one consult, but the main treatment for graft-versus-host disease, as it's been explained, is the immune system is overreacting to a degree to your body, so we will treat it with immunosuppression. It's often steroids, prednisolone perhaps, and that holds your immune system back. You may need other medicines to prevent infections and help manage side effects from the treatment. So sometimes people can feel like they're on tablets because they're taking tablets, and that they're absolutely right. Unfortunately, it's part of the grand plan, and we need to manage the side effects from the immunosuppression to keep you as safe as possible. So that might be anti-infectives like antivirals and so on that Ashvind was saying. It might be medications to help your bone strength. There's a variety of ways these things can do, but keeping close to your treating team will help. And also, for example, I've mentioned prednisolone. There are other medications out there. So each treatment will be different for each person and for each condition. And we will have to often see how people respond to medication before we can change it. And sometimes it can be frustrating for people because they don't understand, or they don't respond and it takes a long time and the whole thing is drawn out. And we will just have to go through that together. But here are some tips and tricks to get you through the process. So whilst there is the right immunosuppression at the right time, ideally, we do have some supportive care tricks. And so I've made a little mind map here, but in general, these are the supportive care needs for patients with chronic graft-versus-host disease. And it is a disease, a chronic disease with a high symptom burden, and I think it's quite isolating, and people can lose their sense of identity and be unable to work, and relationship dynamics have changed. So anything that we can do to support you whilst you're going through that is important. And I honestly find sometimes some of the symptom management works best. So if we kind of go through this mind map, you've got the skin and nails changes. So if it's applicable to you, and you have joint stiffness or restricted range of motion, perhaps, physiotherapy, hand splinting, soft collars can be really effective. Any type of movement that helps people move around. For example, I put the word ping pong, yoga, stretching in there, but I've had someone do water aerobics. Anything that opens you up and keeps you warm is a really good way to help work through some of those symptomologies. I highly recommend an occupational therapist if joint contractures are a problem for you. But also with the cramping, it can be a really debilitating side effect for people. So whilst we're going to treat the underlying cause with an immunosuppressive agent, there are supportive medications that stop you from cramping, dapsone, baclofen. There are, particularly if people have cramping in the jaws, perhaps you could do Botox. Quinine, which is an active ingredient in tonic water, can be really helpful. We don't recommend the gin, but do have the tonic water. Otherwise, magnesium, hot packs, helpful. Super glue if your nails are perhaps peeling apart, which can happen and is really quite frustrating. Sorry, I'm just moving I've got my thing on my phone. If we go to the lungs, the symptoms sometimes might be actually quite subtle, and you'll just be doing a regular respiratory function test before you're told that you have lung graft-versus-host disease. But aerobic exercise, doing lung rehab like they would do similar in the heart failure space can be really useful, as is managing reflux, because that will help the underlying pathophysiology, the underlying reason why this is happening of inflammation. As we've already discussed, avoiding the trigger points such as sunburn or infections, food intolerances are important. Eyes is a really distressing symptom for people, and autologous serum eye drops. Talk to your local transplant center or ophthalmologist. Punctal eye plugs, special eyewear that blocks wind or light, sunglasses is really helpful. For the genitals, highly recommend going to either the Royal Women's or equivalent or urologist if you need help, but lube is really helpful in general. The oral medicine place is pretty much my favorite place to give advice, because we take almost everything in with our mouths, and it can be quite distressing when you have the salivary with the lack of saliva that graft versus host disease can give you, and it makes it difficult to eat. It makes your teeth rot. It's honestly quite a hard time, and most things will sting. So the whole world of saliva production is out there for you. Things like Xylee melts, they're available from a chemist warehouse. Jols, so they're non-sugar sugar lollies, very helpful. Biotine as a brand, not affiliated, but any of their mouthwashes are quite helpful, as is just the general regular 4 times a day mouthwash. You can see the SLS-free toothpaste. The palate preparation applies to people who are particularly challenged with taste changes, be it metallic or otherwise, from the medication that they're on. I've had a few people, so they struggle to eat because of the taste changes, and you can actually help that along. Perhaps you have to do this as a trial and error, but perhaps with a lemon water. The ginger that you could get before a sushi packet, or ginger tea, can really help prepare the palate. One patient swears by cucumber sprinkled with salt. So I just recommend giving it all a go. And it's really important to keep involved with your normal dental team so they can do an infection and an oral cancer overlay, because unfortunately being immunosuppressed makes you at risk of further cancers, which seems deeply unfair after everything you've been through. But yet, unfortunately, it's something that we need to be vigilant about. Just going through my notes. Medication side effects, they're well known and probably experienced by many of you. Of course, the infection risk, which we've discussed, but bones and muscles. What I think the common misconceptions is that the steroids we're giving you are the steroids of Arnold Schwarzenegger, and they are not. These are the steroids that absolutely
Oh dear, we seem to have lost Alex. Just give me a moment and I'll let her know. I'm not sure what's happened there, but what we might do while we're waiting for Alex to come back is we've got a few questions in the Q&A. So what I'll do is, Ash, if you wouldn't mind, if I can ask you to answer some questions that our participants have posted in the chat. So one question is around parotitis. So this lady has said that she has parotitis, which started about 3 years ago. And has anyone on the panel ever heard this happening as graft versus host disease?
So I haven't. The best way I can probably address that is most of the graft versus host disease that we see are usually the ones that kind of fit in the descriptions that I gave. So are restricted to those organs that are classically described. However, quite a few of us have seen different types of graft versus host disease, so they're not often restricted to where you think they may be. So this may include we do occasionally get kind of a muscle inflammation type of graft versus host disease, where you've seen host disease affect people's kidneys as well. So the parotid, it's the gland that essentially makes saliva. So in a sense, it makes sense that it's part of the graft versus host disease, and that may be one of the mechanisms of a dry mouth. So I think Alex's sort of tips about how to manage it, and then also immunosuppression might be the way to go there. But yeah, I haven't come across parotitis before, actually.
Yeah, and I would agree with that, Ash. I mean, obviously there are some really commonly recognised forms of graft versus host disease, but as we know, we do see some rare manifestations as well, and sometimes they can be difficult to pinpoint the actual diagnosis or the cause of that particular symptom, and so it's a process of elimination. And so if there's graft versus host disease elsewhere, that potentially something can be considered graft versus host disease as well. Now there's another question here from
Oh, sorry, I'm back. Apologies.
Alex, we just we started going to the Q&A. Are you there? I think she's actually dropped out again. So what we'll do is we'll continue with the questions.
So sorry, I'll just join the Q&A. My apologies.
Okay, great. So we might stick with the questions just for the time being. So another question from the group is, are the risks of graft versus host disease higher when you are having a second allogeneic bone marrow transplant?
It's a good question. So it also depends on there are a couple of things that inform your risk of graft versus host disease. So first of all, your type of donor also influences the risk of graft versus host disease. So traditionally, we've sort of expected those who have had a matched sibling to be a little bit lower risk of graft versus host disease compared to an unrelated donor, or increasingly we're using haploidentical transplants, so those with half matches. Some of that risk, and in fact a lot of that risk, can be reduced by some of the drugs that we give as part of conditioning. So depending on where you are in Australia, a lot of places, and even the centre that I practice at, use something called thymoglobulin, which is an anti-T cell medication for those with unrelated donors. And then also there is increasing use of a drug called cyclophosphamide, which is a chemotherapy agent after the cells have been put in. So that is also given as a potential prevention of graft versus host disease. The reason why that context is important is because it sort of informs what the second transplant is being done for. If it's being unfortunately done for a relapse of leukemia, sometimes the haematologist may discuss with you purposely omitting some of those drugs because we want as much of a graft versus leukemia effect as we can. So that may inform the risk of graft versus host disease. But I think also from cohort studies, we know, unfortunately, that the risk of graft versus host disease after a transplant may also be higher because of all the specific organ toxicity that you may have had initially with your first transplantation as well. So it's a little bit to do with what's happened before, and also what kind of drugs you'll be receiving as part of your second transplant that informs the risk. Yvonne, you're muted.
Oh, thank you. There's some great suggestions on the chat as well. Tarina has said that ruby berry wafers are wonderful for taste changes and totally natural. So that's
Ooh, I'm gonna put that in my collection of ideas. Thank you, Tarina.
Yeah, so that's great. There's another, Tarina's also said that it can be really difficult sometimes to differentiate between, or make it difficult to tell whether side effects are related to a symptom of graft versus host disease or a side effect of medication? And Ash, I think you mentioned that in your presentation as well, and as you did, Alex, you know, particularly nausea, I think, is a really big one, right?
100%. And yeah, there's a lot of ways to manage this, and I apologize for my technological difficulties. I'll share my slides, and I have a list of resources, and I'll put them through for people, and hopefully, and in general, very lovely, put them out. So sorry about that.
No worries, Alex. Thank you, and completely understandable. There's another question, which is a great one. What can patients and carers do to help their general population team of carers understand the needs of BMT recipients? So, e.g., you know, the regular dentist or the GP who might not see many BMT patients. Alex,
that is my current mission, Yvonne. So whilst I might not have the answer, I have a slide which I will send out to you, which will be the answer. And I think you're quite right that it's really hard for general practitioners and dental people to understand the nuances of this disease. Everyone understands leukemia. What the hell is graft versus host disease? So what I'm going to do, and I'll disseminate it through Jen and through Arrow, is create a list of resources and practitioners state by state that understand, that are familiar with graft versus host disease, so people can have a registry. So this will be free. It will put on the Straight and Marrow website. But in general, there are some good papers that you could give to your, as an interim procedure. There's some papers and some ideas of what people can do, like a whole guideline, and I'm happy to share that through Arrow as well. That'll be helpful for dermatologists, dental, respiratory to follow, because it's honestly not too complicated. It's just that it's niche and it feels foreign, but this is medicine that people have been practicing for quite a few years. They just haven't applied it to graft versus host disease.
Thanks, Alex. We've got time for one or two further questions. There's a question that's come through on the Q&A, which is really topical at the moment. And this is one that we really, really encourage you to speak to your transplant teams about, but I will throw it out to Alex and Ash, and it's around pre and probiotics. The question is, I've read some research that taking prebiotics post-transplant has reduced the incidence of graft versus host disease. Any comment by the panel? Ash, I'll shoot that one at you.
It's a really good question. So it's an area of active research for a lot of transplanters, because there has been some early work demonstrating that an altered microbiome does have some relationship to or some association with a subsequent outcome following a transplant. So and there are some clinical studies that may be starting soon, hopefully, looking at potentially like microbiota transplants in graft versus host disease. I think, it's still the best way I can kind of answer is still an area of active research, and there's a lot of interest into the microbiome, both from the point of view of treatment of cancer, but also about outcomes after transplant. Whether or not pre and postbiotics make a difference, we can't answer that for certain yet. But what I would recommend is, if you're planning to do anything, just make sure you discuss it with your haematologist beforehand.
Yeah, that's a really good suggestion, Ash. All right, I'm going to throw one last question in. You've got about a minute to answer this. And this again is to Ash. So the question is, if you have chronic graft versus host disease, does that prevent relapsing or not?
Yeah, so there are quite a lot of there's quite a lot of evidence that suggests that if you experience some sort of graft versus host disease, your risk of relapse does reduce. It doesn't reduce down to zero. So it's not that one thing will necessarily mean the other. It just means that the risk is lower. And unfortunately, a few of us have looked after patients with both sides of the coin, graft versus host disease and relapse. But we always kind of tell patients it reassures us to have a little bit of graft versus host disease, because it does reduce your risk of GvHD. But it's important that the graft versus host disease responds to treatment and goes away quickly. That they're the things we would want in an ideal world, and often they don't happen. But yes, having some graft versus host disease does reduce your risk of relapse overall.
Thanks, Ash. So I am going to hand back over to Jen, but before I do, I would like to say thanks to Ash and thanks to Alex on behalf of all of the participants in Arrow.